Hi, everyone, and welcome to the Otolaryngology Clinics podcast. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngology Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the August 2021 issue dedicated to biologics and otolaryngology, guest edited by Dr. Sarah Wise, Ashkan Manfred, and Nicole Schmidt. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today I'm speaking with the guest editors of the August 2021 Otolaryngologic Clinics of North America, which is on biologics in otolaryngology. I'm speaking with Dr. Nicole Schmidt, who is Associate Professor of Otolaryngology and Co-Director for Translational Research in the Head and Neck Cancer Program at Winship Cancer Institute at Emory University School of Medicine in Atlanta, Georgia. I'm speaking with Dr. Sarah Wise, who is Professor of Otolaryngology at Emory University School of Medicine in Atlanta, Georgia. And I'm speaking with Dr. Ashkan Manfred, who is Professor of Surgery and Neurosurgery in the Division of Otolaryngology Head and Neck Surgery at George Washington University in Washington, D.C. Thank you guys for doing this and welcome.
Thank you.
Thanks for having us.
Really happy to have you here. This was a very interesting issue of clinics to put together. So normally there's one subject that's covered in detail per issue, and that subject pertains to one specialty within otolaryngology. But this time, the three of you tackled a relatively new but burgeoning subject, the use of biological agents, that covers E, N, and T. Both in your foreword and in the first article that you all three wrote together called Biologics in Otolaryngology, Past, Present, and Future, you address what biologics are and what they might do to help our patients with various ear, nose, and throat disorders. So let's jump into it. Sarah, what defines a biologic agent and which ones appear to be the right immune modulators for rhinology and otology?
Oh, thank you, Sujana. So a biologic agent is really a pharmaceutical drug that's manufactured, extracted, or somehow synthesized from a living source. So there's a wide range of biologic agents. They can occur in vaccines, blood components, gene therapies, recombinant proteins, that sort of thing. But today in otolaryngology and in lots of other specialties, when we use the term biologic, we're typically talking about some type of monoclonal antibody, for example, that has a specific target in a human cell or in an inflammatory pathway, and that has a specific, mostly predictable downstream effect. And so in rhinology, I'll kind of talk just briefly about that, and maybe Ashkan can jump in on the otology question perhaps. But in rhinology thus far, we have FDA approved biologics for nasal polyposis. And so those that are available, FDA approved, and those that have undergone the most in-depth study tend to fall under the type 2 or Th2 mediated inflammatory pathway. And I think we'll talk a little bit more in depth about the specific ones a little bit later. But there are three currently approved that include dupilumab, omalizumab, and mepolizumab.
So I thank you. And I think I really like the figure that you put into this article, the three of you, figure 1, that looks at how interleukin is targeted, and the table that discusses dupilumab, omalizumab, mepolizumab, and also restylizumab and benralizumab. So when Chandrasekhar cannot say the name of a drug, it's got a lot of letters.
Yeah, I think we're all getting used to the alphabet soup of all of these names lately.
Yeah, I agree. We will be talking in much more detail about rhinology and otology, but maybe Nikki, can you give us a little bit of an overview of these agents for head and neck cancer?
Absolutely. So similarly to rhinology, most of the biologics that are coming on board for head and neck cancer consist of monoclonal antibodies and are also considered immunotherapy. But they're sort of the reverse. Instead of dampening the immune response in head and neck cancer, we aim to bump it up. And so most commonly what has made major strides in the past 7 to 10 years or so has been immune checkpoint inhibitors. So immune checkpoints are biologically designed. They exist to prevent exaggerated immunity so that we don't all die when we get the flu. But unfortunately, cancer cells have learned to exploit those immune checkpoints to dampen the immune response and evade killing by the immune system. And so the most common one that's been used in head and neck cancer particularly is programmed cell death 1 or PD-1. And so in this overview article, we give a figure that shows how anti-PD-1 antibodies block that pathway. Essentially, is sort of releasing the brakes to turn the immune response back on against the tumor.
That's a great explanation. If as our listeners are listening, it's worth a rewind and just listen to that again, because I think both of those explanations gave us very succinctly something that looks kind of very difficult to understand if you approach it without that nice overview. So you have a total of 13 articles. The first is this overview article, which I liked a lot. The remaining 12 articles in the issue on the roles is divided into the roles of biologics in rhinology, and then head and neck cancer, and then otology. So let's talk about them in that order. And so Sarah, as the rhinologist of the trio, I think you were responsible for editing the rhinology articles. Which biologic therapies are currently approved for the treatment of nasal polyps, as you discussed earlier, and how exactly is that targeting going on?
Sure. So I think this is kind of covered nicely in the initial article on the rhinology section, and that's current evidence for biologic therapy in chronic rhinosinusitis with nasal polyposis, with Stella Lee as the senior author. So the first biologic that was approved for nasal polyposis is dupilumab. And dupilumab targets the interleukin-4 alpha receptor. And so that's pretty high up in the inflammatory pathway of the T helper 2 cell sort of system. And there are two interleukins that bind to this particular receptor. So that's interleukin 4 and 13. And so by binding to the IL-4 alpha receptor, dupilumab does not allow these interleukins to bind there. And this has significant effects on kind of the upstream regions that eventually affect eosinophils. And eosinophils are particularly important in nasal polyposis. And since I've mentioned that, I'll talk about one of the most recent biologics that is approved for nasal polyposis, which is mepolizumab. And that targets interleukin 5 directly. And interleukin 5 is highly important in eosinophil recruitment, survival, perpetuation. And so that particular biologic, like I said, has recently been approved for nasal polyposis, although was approved previously for asthma and some other disease processes. And then the final one is omalizumab, which targets IgE. And we typically think of IgE as being associated with allergic pathways. Omalizumab has been around for quite a long time. We actually saw some of our nasal polyp patients on omalizumab quite some time ago, and they were receiving it for asthma. And so although the indication for omalizumab for nasal polyps is relatively new, it is something that's been around for a while. So we tend to think of that particular one in our patients that have a little bit more of an allergic profile.
I think that leads very nicely into the next article by Drs. Platt and Brook, which really helps us determine within these options how a treating physician selects a biologic in particular for that individual patient, again, with recalcitrant nasal polyps. So we're not talking about first line treatment by any means, but how do you decide which one of these agents, how do you decide where the target would be the ideal for the patient in front of you?
Sure. So I think, as I've mentioned, the biologics are really targeted at different aspects of the inflammatory pathway. And so, we really want to think about what type of inflammation our patients might have. So at least here in the US, most adult patients with nasal polyposis are going to kind of fall under that Th2 or type 2 mediated inflammatory pathway. Many of them will have significant eosinophilia in the tissues. Some will have allergies. So some of the things that we look at are oftentimes these patients are undergoing endoscopic sinus surgery. So I tend to look at the eosinophils, in their tissue. What type of report am I getting from the pathologist? Are there lots of eosinophils, or do the patients have, some other type of inflammatory milieu in their tissue? Oftentimes, we'll also get a blood eosinophil count, which we can obtain by getting a CBC with differential. Lots of rhinologists will also order a total IgE in the serum as well. So a couple different blood tests. We look at, does the patient have asthma? Do they have other sort of allergic phenomena or other atopic conditions that might kind of give us clues that they fit into systemically into a certain sort of subtype or endotype. Unfortunately, there are not great biomarkers for assessing which patients are going to respond to individual biologics, and also there are not great markers for following patients once we've placed them on a biologic. But we kind of try to get a general gestalt of what the patient's inflammatory profile is, what their comorbidities are, and then sort of select the biologic based on those sort of subtypes. And most of these patients, as you said, the vast majority will be patients that have had one or oftentimes multiple sinus surgeries. They've done standard therapy with high volume topical steroid irrigations. They've had some have had allergy testing and immunotherapy and, all of those sorts of things. And so these are our truly recalcitrant patients that we're considering biologic therapy for.
So you mentioned briefly that we actually almost acquired patients who happened to have nasal polyps and who were on biologics because they were on them for their asthma. So let's talk a bit about allergy and asthma. And are you guys still calling it the unified airway?
Yes.
I love that. I think it's the greatest way to explain it to myself and explain it to patients, frankly, that it's not whatever happens in the front happens, lower down. So can you talk to us a bit about how you might separately assess the patient who has chronic rhinosinusitis with polyps, who also has allergy and asthma that are none of which are responding well enough to those first or second line therapies?
Sure. And, I'd like to at least start out by giving credit to a lot of the other specialists that we work with, allergists, immunologists, pulmonologists, et cetera. So oftentimes these recalcitrant patients are not only in our, tertiary rhinology clinics, they're also in our tertiary allergy, immunology, pulmonology clinics, dermatology clinics, et cetera. So, we can't just practice in a tiny little box of the nose and sinuses. We have to really look at the whole patient. And so oftentimes these patients with chronic sinusitis with nasal polyps will have other comorbid conditions like asthma. That's an incredibly common one. Some with aspirin sensitivity, some with environmental allergy, or other allergic phenomena like atopic dermatitis and those sorts of things. And a lot of the biologics that we use for CRS with nasal polyps are actually biologics that were previously approved for other indications, such as recalcitrant asthma, atopic dermatitis, urticaria, eosinophilic granulomatosis with polyangiitis or EGPA. And so a lot of times our colleagues in allergy and immunology and pulmonology will have had experience with these biologics on these very same patients. And so we can really work together with them. There are also otolaryngologists that will treat asthma and some of the skin manifestations with biologics as well, typically in a fairly specialized practice. So one of the articles in this edition talks about allergy and asthma indications for these biologics, and that's by Drs. Damask and Francis. And there's a really nice table in that article that talks about some of the pivotal trials for these various biologics that led to their approval for asthma. There's also a nice figure that looks at type 2 inflammation and is complementary to the figure in the initial article in this edition. So I think really the main point of all of this is for us to make sure we're looking at the whole patient and thinking about not just their upper airway, but their lower airway, potential dermatologic manifestations, serum eosinophilia, all of these things.
So do you normally manage these patients individually? Do you have a multidisciplinary clinic where people see them? What's the best way for the patient to get a streamlined but comprehensive eval and management by all of these various specialists who are involved in their care?
Sure. So as far as at least in our department, one of the places that sometimes these patients will present is to our multidisciplinary cough clinic that are laryngologists, pulmonologists, allergists, oftentimes we'll see the patients together. And this in COVID times, this actually came to fruition by actually a large sort of telemedicine conference of a multidisciplinary cough clinic, and it's actually worked out great. And if they suspect that the patients have nasal polyps, then of course we'll see them as well. And a lot of times nowadays, if the patient comes to one provider in the clinic or on telemedicine, it's very easy to get them seen fairly quickly on a virtual visit by another provider or another clinic, at least for an initial evaluation. And then of course, testing or CT scans or other things can be arranged later. So, I think we've learned a lot in these COVID times for, how we can streamline care. And so even if it's not necessarily a multidisciplinary clinic for an individual complaint, we can get people seen pretty quickly because of our virtual capabilities nowadays.
That's wonderful, right? There's always some good that comes out of bad things. We just have to find them. And I think as we wrap up the articles on rhinology, where there is the most data for the use of biologics, I think, once you start somebody, what's the end game? Like, how long should patients remain on biologics? Like, what are we learning about, how do we counsel them regarding their plan eventually?
Yeah, so the short answer is we don't entirely know. We're learning as we go along. So some of the data that has come out of the nasal polyp studies is from the original dupilumab trials in nasal polyposis, basically showing that in the group that was treated with biologics initially for about 24 weeks or so, and then discontinued at approximately a year, they reapproached their baseline symptomatically. So that would tell us that if the biologics are withdrawn, then there's certainly a possibility that a patient could worsen. I think we always have to keep in mind that when we're treating an individual patient, each individual person does not necessarily follow what we see in the clinical trials. And so I think we have to kind of keep our mind open to what's going on with each individual patient. And in the real world, certainly we have real world events like discontinuation of insurance approval, or inability to get the drug for various reasons, or patients decide that they no longer wish to give themselves injections, or what have you. And so as I've watched my own patients over time, I have certainly seen people that have either spaced out their doses of their biologics, or they have discontinued for various reasons. And, some of them do worsen. And I would say that where they particularly notice that they get worse is oftentimes in their breathing. For their asthma, their chest is tighter, they start coughing more, they're able to do less activities, et cetera. And they start to notice some nasal and sinus complaints as well. Other patients seem to do okay, at least in the short term. We've not had biologics available for nasal polyps or approved for nasal polyps for an incredibly long time. So I think we're still learning a lot about what the future is going to hold and really how long patients need to be treated. I guess we shall see. I think the last thing I'd say is I just want to highlight that there are lots of things that we don't know about nasal polyps and biologics, and a lot of those are enumerated in the final rhinology article by Dr. Rowland and Levy, looking at knowledge gaps and research needs. And table 1 in their article is fantastic, kind of gives a brief rundown of lots of different research needs that have been identified in this field. So.
Thank you. Thank you, Sarah Wise. That was very wise indeed, and really summarized beautifully written articles that explain something that is definitely helping a subset of our patients who really needed that help.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Dr. Sujana Chandrasekhar. I'm consulting editor for Otolaryngology Clinics of North America. And today I am speaking with the guest editors of the August 2021 issue on biologics in otolaryngology, Dr. Nikki Schmidt, Dr. Sarah Wise, and Dr. Ashkan Munfarid. Doctors Schmidt and Wise are from Emory University School of Medicine in Atlanta, Georgia, and Dr. Munfarid is from George Washington University in Washington, D.C. You can find all the issues of Otolaryngology Clinics of North America and all of our podcasts at www.oto.theclinics.com. And you can obviously find our podcasts wherever you listen to your podcasts. If your medical center or hospital library does not carry clinics, please encourage them to do so. I remember reading them as a very young trainee and being fascinated by how well each issue covered something from soup to nuts. And I think that the caliber of the clinics has only gotten stronger with such expertise as you hear on these podcasts. So we've finished the rhinology portion. So Nikki, let's turn our attention to head and neck cancer. And I think your point that biologic agents in head and neck cancer are designed to work very differently than they are designed to work for airway disease, like chronic sinusitis with polyps or asthma or allergy. It was really interesting. So let's expound on that a bit. We briefly discussed the anti-PD-1 checkpoint inhibitors earlier when we talked about your summary article. So in what situations are they approved for use in head and neck cancer?
That's a great question, Sujana. There's a lot of research being done, but so far, the anti-PD-1 checkpoint inhibitors are only really approved for patients with recurrent or metastatic disease. So there's, again, a lot of research and a lot of movement in the setting of previously untreated locally advanced disease and where do these drugs fit there. But so far, they're really only in common use in the recurrent or metastatic situation. So basically, if a patient has already had chemotherapy with radiation, essentially they've failed platinum chemotherapy, then they are already considered platinum refractory. And in 2016, nivolumab and pembrolizumab, which are both PD-1 and checkpoint inhibitors, were FDA approved for the use of for use in that setting. So basically, if a person has already been treated with chemotherapy along with radiation, then they can go straight to immunotherapy. But in a situation where maybe a patient had surgery and radiation but never saw platinum chemotherapy, prior to recently, patients had to get some form of platinum chemotherapy if they were eligible prior to receiving immunotherapy. So that was an extra step for some of our patients. And then more recently with the KEYNOTE-48 trial, they compared chemotherapy versus with or without cetuximab versus anti-PD-1 drug, which is pembrolizumab. And what they found was for patients whose tumors actually express a fair amount of PD-L1, that pembrolizumab is just as good as chemotherapy up front. And basically, so now that's been FDA approved for first line, even in patients who have never seen platinum chemotherapy. So that's what we're using it for right now. There are a lot of other drugs that are coming online for the recurrent or metastatic setting that are not yet FDA approved, but many of them are in earlier advanced stage clinical trials. And as I mentioned earlier, these anti-PD-1 drugs are in clinical trials for previously untreated disease, either along with standard therapy such as surgery or with chemotherapy and radiation. And you know, it's a very exciting but very intimidating and fast-moving field. And even for a tumor immunologist as myself, it's a lot to unpack. And so to kind of target those, you know, those strategies and summarize them, our first article in this head and neck series was just really focusing on strategies for immunotherapy in head and neck cancer. And I recruited a colleague, Dr. Buchwald at Emory, to write that with me. And so in table 1, we tried to give just an overview of the generic strategies, which can really be broken down by either releasing the brakes, which these checkpoint inhibitors can do, or stepping on the gas, basically getting some things to unleash an immune response. Because the important thing about checkpoint inhibitors is that they really do release the brakes, but if there's no immune response underlying those brakes, then these drugs just don't work. And so we tried to kind of summarize the generic different strategies and just give an overview of that. And then the indication that you mentioned, Sujan, are listed at the end in the clinic care points, where we discuss what's active right now for our patients and what's really on the radar and undergoing investigation at the moment.
Thank you. Yeah, I think that, I'm an otologist, but I have to say I'm insatiably curious, and I love to learn what's new and happening. And I think just like I commented on the previous articles, I think your section's articles take this very complicated information and break it into a way that somebody like me, who basically does earwax for a living, can understand that. So you're talking about patients with head and neck tumors, and as Sarah mentioned, we still need to learn about biomarkers of who is a candidate, who is not a candidate. What biomarkers are you using in head and neck cancer to assess whether the tumor is responding or resistant to the biologic agents that you're giving?
So that's another great question. And it's really important because these drugs in the recurrent metastatic setting that I mentioned, even first line, only work in about 20% of patients. So about 18 to 20%, depending on the clinical trial, will have some shrinkage of their tumor and a clinical response. What I think a lot of people don't realize, though, is that a lot of patients will benefit in the form of stable disease. So another 20 or 25% or so will have their disease stay, exactly stable for months or years, and that's actually not trivial. And so if you add all that together, almost half of our patients will have some degree of benefit, but it is expensive therapy, and a lot of patients have hope, and you wait for several weeks or months to find that it doesn't work. So we desperately need biomarkers to figure out who will respond to these and who would benefit from other agents or high quality palliative care. And so to that end, we dedicated a whole article to this topic. My colleagues, Drs. Maroon and Mandel, did a wonderful job. What I love about their article is that they actually started off by spending some time talking about the immune response, how it works, and what the general mechanisms of resistance are. And so that was a nice tie-in to basically understand the biomarkers that we have, which are limited, and the great need for better ones and where the research is in that. What we do have so far, we do know that tumor mutational burden is important. So essentially, to be recognized by the immune system, a tumor must express something that is foreign. And that can either be highly expressed proteins that like EGFR that are out of proportion to other cells, or it can be a viral protein like an HPV oncoprotein, or it can be a mutated protein, which is known as a neoantigen. And so if those are more likely to be recognized by the immune system, then it's logical that tumors that have a lot of mutations have an increased chance of being recognized by the immune system. And so again, when going back to this point where checkpoint inhibitors are releasing the brakes, but if there's no underlying mutations to incite that immune response, then they won't work. And so that's been a relatively reliable biomarker system, but it's not perfect. The other one that's used now commonly, as I mentioned earlier, is PD-L1 expression by the tumor. So a tumor that expresses higher levels of PD-L1 is more likely to respond, but that's also frustratingly imperfect because a lot of patients have a PD-L1 score greater than 1 and they still will not respond. And so even when you combine these things together, we're still a major gap where we need better research and better biomarkers. And lastly, the data are mixed, but overall, they do suggest that patients with HPV positive tumors do have a higher likelihood of responding to these drugs. We think that may be due to the underlying immune response to the viral proteins, as I mentioned earlier. But again, the data from one trial to another are somewhat mixed on that. So, a lot of exciting work going on in this realm. And the article in the clinic care points at the end really summarizes what we're using and what the knowledge gaps are.
So, you mentioned EGF receptor targeted therapy, and we're expanding from sort of what we know and what we know we don't know to maybe what we should know. I sound like some sort of politician, so I'm going to stop talking about that. What are some of the other exciting immunotherapeutic strategies that are under investigation?
So that's a really good question. So basically, one of them has been right under our nose for a long time, which is cetuximab. And essentially, that is the oldest FDA-approved biologic for head and neck cancer. It's been FDA-approved in the upfront setting along with radiation, and in the recurrent metastatic setting along with chemotherapy for many years now. And it's interesting that it's actually a monoclonal antibody that's chimeric human and mouse. So it has a mouse FC receptor. And interestingly, when patients respond to cetuximab with head and neck cancer, they often get a acneiform rash. And that's usually a sort of a behavioral biomarker that the drug is working. And it's interesting. The history of it is very, very fascinating to me because there were attempts made to try other EGFR tyrosine kinase inhibitors and also other antibodies. And one in particular, which is panitumumab, was made to be a fully humanized IgG. And the thought was that it would be less toxic than cetuximab without this rash because it's a fully humanized antibody. And it was less toxic, but it was also less effective. And studies have shown that. And this history and this conundrum, if you will, is very nicely summarized in the article on EGF receptor targeted therapy by Drs. Trivedi and Ferris, who've been doing research on this for many years. And essentially talking about how we think cetuximab works as a form of immunotherapy, not as an EGFR targeting agent. Also, we do have some disappointments with cetuximab in terms of it doesn't work on everybody, and we need better biomarkers for when it works. But in the meantime, we're learning a lot more about it and how to pair it with other things to maximize its potential.
So this is the one time when somebody breaks out with acne and we're excited.
That's exactly right.
Like, yay, you got zit. We've talked about squamous cell cancer, and obviously as a head and neck surgeon, that's your primary focus. But there are other head and neck neoplasms that might be treated with immunotherapy as well, aren't there?
There are indeed. We thought about including an article about salivary tumors because there's been a lot of movement in biologics and targeted therapies for salivary tumors, but I discovered that was recently covered very nicely in a recent issue of Clinics. So we decided to not double cover that. And one thing I really wanted to highlight was the movement that's been made recently in recurrent respiratory papillomatosis, also known as RRP. It's a fascinating disease that is also HPV related, similar to oropharyngeal cancer, but there have been a lot of difficulties in moving that forward. And it's been traditionally known as a surgical disease where these poor patients get surgery over and over again to maintain their airway and their voice. And over the years, things such as cidofovir and other antivirals have been used with very little data. Preventive vaccines have been disappointing in the disease setting. And so the article about this by my colleague Clint Allen covers this very nicely, all the new data on either anti-angiogenic or immune therapies for RRP. And there's a lot of really exciting happenings going on there. So that's really nicely summarized in his article. And not only what the data show, but also how they're purported to work and where the future research is going. So I thought that was a really nice thing to highlight. And finally, some hope for this disease, which is very, very difficult.
So, there's another aspect as clinicians when we treat recurrent respiratory papillomatosis, right? So every time we are going in surgically either with cold steel or with laser, we are potentially exposing ourselves and our operative team to airborne particles and potentially seeding the upper airways of ourselves and our team. So do you think adding biologics to this RRP group actually helps reduce that exposure for the surgical team?
That's a really good question. It's hard to say what that does to the actual viral load. Over time, I see RRP becoming less of a surgical disease and really more of an immune disease. It really, Dr. Allen in his article really lays down nicely how his rationale for the fact that this is an immune disease. And as we target it more, and studies with immunotherapy and anti-angiogenic agents are showing less of a disease burden, and theoretically there would be less viruses there. And if it definitely can have the potential to decrease the frequency with which we're taking these patients back to the operating room and the severity of what we're liberalizing in those smoke plumes.
Right, well, thank you. And then as we wrap up your section on head and neck cancer, can you talk to us about other biologics that are either in use or under investigation for head and neck tumors?
Absolutely. So one thing, in addition to the monoclonal antibodies that Sarah and I have spent much of this podcast describing, what I love about head and neck cancer in terms of biologics is the work that's being done recently in adoptive cell therapy. So as Dr. Wise mentioned earlier, a biologic is basically some type of therapeutic product from a living source. And in addition to monoclonal antibodies, it can actually be cells. And so there's this burgeoning field where you can take a immune cell, and particularly cytotoxic T cells are really the ones that are primarily responsible for fighting cancer cells. And you can remove them from a patient, grow them in culture, make them better in some way, and then put them back in. And that's just, to me, just a mind-blowing phenomenon, and something that you could see would only happen in a very boutique setting. But it's actually going mainstream in clinical trials. And so the other things that have gained popularity primarily in hematologic malignancies are CAR T cells. And again, those are chimeric antigen receptor T cells, where you take a T cell and you engineer a chimeric antigen receptor that can bypass the need for the antigen to be presented on the surface of a tumor cell. And these T cells can directly attack any tumor cell that expresses a particular surface protein. So that is really revolutionizing the field of cancer immunology. And it's been difficult in solid tumors because it's difficult to find a receptor that's expressed on most tumor cells without having on-target, off-tumor effects and a lot of toxicities. And so to that end, my colleagues, Drs. Norberg and Hinrichs at the National Cancer Institute wrote a very nice article summarizing all the work that's been done in adoptive cell therapy, primarily their work and some by others, taking T cells and engineering them to attack HPV expressing tumors. So, you can take an E7 expressing T cell receptor and put it onto a patient's T cells, expand those T cells in culture, and then reinfuse them again. And they've had some spectacular results in a subset of patients. They've treated HPV disease not only of the oropharynx, but of the cervix and other tumor sites. So I really like their summary of the clinical trials to date and some of the remaining challenges there are.
Thank you so much. That was Dr. Nikki Schmidt of Emory University School of Medicine in Atlanta, Georgia. I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. And today I'm having a really terrific time talking to the three guest editors of the August 2021 issue of Clinics, which is on biologics in otolaryngology. We heard from Dr. Sarah Wise from Emory University School of Medicine in Atlanta, Georgia on the rhinology. We heard from Dr. Nikki Schmidt, also from Emory University in Atlanta, Georgia, and on head and neck tumors. And now we are going to turn to otology with Dr. Ashkan Munfarid from George Washington University in Washington, D.C. You can find all the issues of Otolaryngologic Clinics of North America and all of our podcasts at www.oto.theclinics.com. And if your library doesn't carry it, please encourage them to carry it. They're really fun to read through and learn from. So Ashkan, again, I think you almost had the hardest job as a guest editor of this issue, because for rhinology and head and neck, biologics are somewhere between infancy and toddler. And for otology, it's almost like, you know, pre-birth or neonates, right? We're very, very early in our understanding of when we can use them and how we can use them. But I think there's a lot of promising data that we can discuss. So can you share with us what advances there have been in terms of biologics for otology?
Of course, yeah, I agree. And otology, I think we're still at a sort of an 8-cell zygote stage when it comes to where biologics fit. But there lies the promise also, because there is so much unknown in our field, particularly when it deals with inner ear, hearing loss, tinnitus management, vertigo. These are conditions that we have very little understanding of the true pathophysiology. Many of these conditions may be even more than one disorder. We lump them all together. And I think biologics would have an opportunity not only to provide treatment, but better even diagnosis, what diseases they're actually dealing with. So in terms of lumping the biologics together, the one area is treatment of hearing loss, and that's revolves around biologics and also gene therapy. There's more than 36 companies now starting on treatment of sensorineural hearing loss, which is a condition that affects about some 500 million people worldwide. It is the most common sensory deficit that affects human beings. So it's certainly a very promising area, but unfortunately, none of the biologics in the area have so far proven to be curative. Of course, they're all in a very early stage of research. The second area has been the growth factors used for tympanic membrane perforations. And in the article that Dr. Gergel wrote with Dr. Gordon, they very nicely delineated all these growth factors, all the studies that have been done. I highly recommend for our audience to take a look at this article, because it gives them a sort of a bird's eye overview of where we are and where we're going with biologics in terms of growth factors for tympanic membrane repair and regeneration. The last area, which is a desperately needed area of improvement, is treatment of some of the skull-based tumors, such as chordomas and schwannomas that are part of neurofibromatosis type 2. And that's another area that there are quite a few, about almost a dozen new agents that are being trialed.
So I think when you included the 3 articles that you included, I think that it was very deliberate in going from things that we know the most about to a little bit less, but things that are really affecting either huge numbers of patients or smaller numbers, but in a very debilitating manner. I like the way you organize that a lot, actually. So let's move from the Gergel article to immune-mediated hearing loss in particular. And this is the article written by Dr. Andrea Van Butis and Ms. Davia. And they have a really nice table 1, on targets and appropriate agents for immune-mediated hearing loss. And the article talks about why steroids often work, which is very nice for us to know, since our knee-jerk reaction to hearing loss is steroids. Can you highlight some of the points that they make in this article?
Absolutely. It's a beautifully written article and talks about a condition that is very poorly understood. It is a condition that so far has been only defined as progressive, usually bilateral, slow sensorineural hearing loss that responds to steroids. If it does not respond to steroid initially, usually we cannot give it the diagnosis of autoimmune or immune-mediated ear disease. then the problem is over time, majority of these patients will stop responding to steroids. So for the very diagnostic criteria, we have no treatment. My personal theory is that this is probably more than one disorder that we're lumping together. And Dr. Mambides beautifully mentions that some of these may not be autoimmune and what she calls autoinflammatory disorders that have a different pathways. And there's a really nice diagram in there for audience to refer to see the difference between autoimmune and autoinflammatory disorders. And there is a very promising new agent. It's an IL-1 inhibitor that her lab has used and she's been using in patients also to treat some of these patients that at least are initially steroid responsive, but then become steroid resistant in the course of treatment of the autoimmune disorders.
I have to say that I was very fortunate to work with Andrea to provide some of the patients and some of the blood samples for these patients. But I think you're right, expanding our definition of autoimmune ear disease from only response to steroids to responds to any immunomodulation allows us to look at these patients very differently. You know, you did mention the problem of skull-base tumors, of neurofibromatosis 2, of chordomas, of glomus tumors, other lateral skull-base tumors of concern. You know, we heard about how biologics are used differently when we're looking at certain types of inflammatory responses like nasal polyposis and other types of inflammatory responses like uncontrolled cancer. So what's happening in these benign but very aggressive sometimes skull-base tumors that we deal with at the lateral skull base?
To give a background, as you may know, these tumors, which mostly include either patients with NF2 that have multiple meningiomas and usually bilateral acoustic neuromas or vestibular schwannomas, or patients with hereditary paragangliomas that have multiple neuroendocrine tumors, such as glomus tumors. Because of their location and vicinity to very vital structures, treatment usually has revolved around surgery and radiation, and there has not been any successful chemotherapy agent for these. There are about a dozen new biologics being trialed because the Merlin protein that is the main reason that patients develop the pathway that patients develop neurofibromatosis interact with so many other proteins during the cell cycle. And because of that, all these other interacting proteins have become targets for biologics. Unfortunately, majority of these trials have revolved around halting the progression of disease. They are not curative. Even those trials have very, very humble outcomes, unfortunately, around 20%, 25%, 30% of patients with good response. The dominant one is the anti-VEGF, which goes by the trade name Avastin, that has been used for breast cancer and has been used in patients with NF2 to halt progression of these very large, devastating vestibular schwannomas. And there's some promise in terms of restoring some level of hearing and halting the progression of the disease. But again, there's a lot of room for improvement still where we need to be with these.
I think the article by Drs. Raskin and Bornhorst, which covers these skull-based tumors, provides a very interesting table 1 that looks at targeted treatments that for use in the skull base, which includes anti-angiogenesis drugs for schwannomas, meningiomas, chordomas, and endolymphatic sac tumors. It looks at tyrosine kinase inhibitors for schwannomas, meningiomas, and chordomas, and it looks at mTOR or mammalian targeted rapamycin complex inhibitors for schwannomas, paragangliomas, meningiomas, and chordomas. And I agree with you. I think we are in our infancy, but these are patients who really need our help. And I thought the beauty of how the 3 of you put together this issue was that we didn't operate in our silos from ears, nose, and throat, but we actually are learning from each other to say, oh, this is how this works in the unified airway. Oh, this is how that works in RRP. How can we work with our colleagues in the House of Medicine to make life better for all disorders that affect all of us? So I want to thank you all three very much. I want to let our readers know that the August 2021 issue of Otolaryngologic Clinics of North America, which is on biologics in otolaryngology, contains the last two articles in the special article series called Intentionally Shaping the Future of Otolaryngology, which was guest edited by Dr. Jennifer Vilwalk from the University of Kansas Medical Center Department of Otolaryngology. And those two articles are Women in Academic Medicine and Leadership by Dr. Mona Abaza and Balance versus Integration, Work-Life Considerations by Drs. Julie Way and Jennifer Vilwalk. That series began in August 2020 with two articles per clinics issue from then until August 2021, with the exception of December 2020, where the special articles were devoted to COVID-19. And you can find those articles at the conclusion of those clinics. I've already recorded the podcast conversation with Dr. Vilwalk about this special article series, and you can find that at the www.oto.theclinics.com or wherever you get your podcasts. You know, part of Women in Academic Medicine and Leadership, and Ashkan pointed it out to me, he said he was very comfortable being the only man in the room for this conversation. I will tell you that I called up one of my friends, a very senior person in head and neck cancer, and I said, hey, who do you recommend that I should ask as a guest editor for the biologics clinics? And of course she said, oh my God, the best person you can find is Nikki Schmidt. And you know, that's how you pay it forward. That's how we learn and hear new voices and wonderful voices who have clearly so much to share with us. I'm Dr. Sujana Chandrasekhar, and today I've had the pleasure of speaking with the guest editors of the August 2021 Otolaryngologic Clinics of North America on biologics in otolaryngology. And they are Dr. Nicole Schmidt, who is Associate Professor of Otolaryngology, Co-Director for Translational Research in the Head and Neck Cancer Program at Winship Cancer Institute at Emory University School of Medicine in Atlanta, Georgia. Dr. Sarah Wise, who is Professor of Otolaryngology Head and Neck Surgery at Emory University School of Medicine in Atlanta, Georgia. And Dr. Ashkan Munfarid, who is Professor of Surgery and Neurosurgery in the Division of Otolaryngology Head and Neck Surgery at George Washington University in Washington, D.C. Nikki, Sarah, and Ashkan, thank you so much for taking the time and effort to compile the August 2021 issue of Clinics on Biologics and Otolaryngology. That work involved agreeing to do this project and then identifying and inviting authors who are leaders in this brave new world, as well as spending this time with me recording this podcast. So thank you so much for joining me today, and thank you to our listeners for listening and for reading.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on biologics and otolaryngology, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast on Apple Podcasts and Google Play.